This is a rapidly moving program, and we've got a very special guest for our second plenary talk, and that's Dr. Jon Andrus. Jon is the Deputy Director of the Pan American Health Organization, and generally speaking, what happens is the Deputy Director of PAHO, which is the regional Center for Health for the World Health Organization, is selected by the U.S. government, and Jon was selected in 2009 to represent the United States government and to be the Deputy Director of the Pan American Health Organization. He has a long and distinguished history of service in public health, including a long tenure at the CDC, and he's an incredibly able physician and public health expert, and it's truly an honor to welcome Jon here today to address us on the Pan American Health Organization's perspective on what we're talking about today. Jon.
Thank you, Peter. Thank you and the rest of the organizers for inviting me. I'm delighted and honored to be here to represent the Pan American Health Organization to address from neglected tropical disease treatment to prevention, the path towards vaccine introduction in the Americas. And what I intend to do is share with you our experience in tackling the challenges of making accessible those new vaccines, particularly the childhood vaccines with the potential for saving lives that have become available more recently. And one of the things in addressing that challenge, which will be certainly very, very applicable when folks like Peter and other scientists make vaccines against neglected tropical diseases, we will be positioned based on our experience to use the evidence, make the right decision for either introduction or not, and then rapid deployment. Now, what I'd like to do and in the rest of my talk is really highlight capacity as being a key guiding principle in this work. And so the objectives I'm going to cover recognize the key factors that contribute to capacity development and country ownership of national programs. And you'll hear me refer to this throughout the talk. Capacity development is key. You can't just have technology alone. And also, at the end, use as a case study how the capacity of an organization like the Pan American Health Organization can be used to help countries purchase more affordable vaccines and sustain an affordable, safe access in terms of a vaccine supply. I'm going to digress a little bit with my first two slides. This is my first overseas assignment back in the mid-'80s. I was trained as a family physician, so when I went to Mchinji District, Malawi, to be the district medical officer, I was trained to handle obstetrical emergencies, and was able to do so despite the conditions of no electricity, no running water, and this was the operating theater. But 1986 was the year of the immunization, and although I was trained clinically, I probably couldn't spell epidemiology at the time. I probably had 2 weeks of public health epidemiology in medical school, and so it was really flying by the seat of my pants. And I was able to do so because I trained 3 Malawians in high-risk obstetrics, and I was free in 1986 to spend time on what was a very important initiative, because immunization coverage in Malawi and in many countries of Africa was only 30 or 40%, if not lower. You know, EPI had been formed in the late 70s, but by the mid-50s it became clear to WHO and UNICEF and other global partners that the capacity to absorb the immunization, the vaccines, the infrastructure that was needed to deliver services was not yet there. And so the focus in 1986, and it was appropriately called 1986, the year of African immunization, was training the district healthcare providers, healthcare workers to deliver services. Again, getting back to that capacity. And what I personally observed, and I've carried this throughout my career, is that when you invest in people, the human resource side of capacity, referred to earlier in the teaching work and subsequent career development of students. But the investment in people, investment of the healthcare worker perhaps already there, combined with that potential of prevention, particularly through a technology like vaccine, I saw an unbelievable process. I saw people like the nurses who lived in homes, 2 or 3 nursing families per home, maybe a 2 or 3 bedroom home provided by the government, but yet 2 or 3 families with all their children, probably being paid less than I was as a Peace Corps volunteer. When the resources became available to prevent the diseases they were seeing killing children every day, there was this injection, a bolus of enthusiasm that I decided that I want that. I really want that, and I want to be involved with that for the rest of my career. And that's basically, I've been so blessed to be able to do that. So it's that investment in people, investment in capacity, and coupled with the available technology that's certainly applicable to when new vaccines for neglected tropical diseases become available. So enough digression, but measles, here's an example. In 1986, we had a measles ward that was a huge killer of children, 2 or 3 children per bed, and I knew it was a bad day if I could hear the mothers crying in the yard. Measles in Latin means miserable, and we have a vaccine, and fortunately in the Americas we've been able to eliminate endemic transmission of this disease. But when we talk about new vaccines, what we're talking about is that gap of availability. When new life-saving vaccines become available to industrialized countries, this chart for us says it all. You see in green the availability of vaccines over time on the horizontal axis. There is this gap. In any one period of time, we're challenged to reduce that gap if we believe in the values of equity and access to provide such interventions. And so what we have done at the Pan American Health Organization is focus on 2 areas of work in terms of taking advantage of new vaccines. One is acceleration of the policy process, because if you don't have a policy process or your process is very slow, you can see how that would impose an impediments to the potential of saving lives. And the other is once the policy process has been conducted, the decision has been made to introduce the new vaccine, then it's rapid deployment. And I'm going to use a case study of rubella elimination to illustrate the rapid deployment. And it's that sense of urgency. In the private sector, time equals money. In the public health sector, time equals more children or more people dying. So injecting that sense of urgency in our work. And just as an example, a current challenge that we have is the burden of disease due to cervical cancer in our region. In most countries, it's the leading cause of cancer deaths among women. We see more than 77,000 new cases per year, greater than 30,000 deaths. And how do we take advantage of that new vaccine against HPV, reducing that time lag that I mentioned, because that does equate to deaths, And doing so where you're not robbing Paul to pay Peter, it's not a zero-sum game. So it's expanding the fiscal space to make this particular vaccine available. It could be expanding the fiscal space through a new partnership of supporters. It could be expanding the fiscal space at a government level, better managing their resources. In the case of Costa Rica, initiating a lottery system where the benefits of the lottery was able to pay for their national vaccine supply. There are innovative approaches to expanding fiscal space. And the approach we're taking along these lines is one to develop the evidence. And the evidence should be comprehensive. It can't just be one cost-effectiveness study, or it can't be just a study on the disease burden. It's a combination of a number of factors that can be grouped under the technical criteria, like the disease burden, like the epidemiology, like the technical characteristics of the vaccine. Is it a live vaccine? Is it killed? Can it be stored in a refrigerator? Can it be given orally, and so on? And then there are programmatic criteria, the cold chain, the capacity to deliver the vaccine in terms of the human resources that I mentioned, the training, and so on. There's social criteria that would include the economic studies, the political commitment, or even the public perception of risk. So this is what we call a decision package in helping countries make the decision. In the old days, at the regional level, when vaccines were penny a dose, we could say, here's the evidence to eradicate polio. Here's the evidence to eliminate measles or rubella with vaccines that are pennies a dose. Now that they're much more expensive and the burden goes to the countries, it has to be really a bottom-up decision. The countries have to use their evidence, their local situation, to better prioritize their interventions and prioritize their health problems. So that's the general approach. We've been very fortunate to received support from the Bill and Melinda Gates Foundation. We call this the PROVAC initiative, and really its mission, and very simply, is to enhance national capacity to make evidence-based decisions with regards to new vaccine introduction. Now, there are 5 objectives, beginning with the strengthen the infrastructure. This often involves the National Immunization Technical Advisory Group. Here in the United States, we have the CDC ACIP, so it would be equivalent to that kind of technical policy making group that in some countries they have this mechanism, but it doesn't function well. They may not have an economist on the team. They may not keep adequate records. You may not have access to the notes for the records, or their minutes, or the reports of the proceedings, of the discussions. They may not meet regularly. So it's really a management problem. In other countries, it does not exist. So how do we go about ensuring that this part of the work is being done and done well? The second objective is to develop the tools. An example, the HPV disease burden that I showed, we have a vaccine. Now, how does a country do the cost-effectiveness analysis and other economic analysis as a part of the overall decision package? Because this is the request for support that we're receiving. And to do so in a way that's user-friendly, that a national program can use. And so in the example of HPV, Sue Goldie and her team at Harvard has taken the tool that they've used to produce and publish very rigorous science with the software and tools that they've used and developed, and modify them so that they're more user-friendly, practical, that a national team can use, that still maintain the scientific rigor. Then the third objective is to help the countries collect the data, populate these tools, and produce the results. The idea is do no harm. And so there's a lot of technical cooperation required so that the right data is used, and in particular, the results are interpreted correctly at this stage in the program. When they're misinterpreted, that's where we can do harm. Either a vaccine that should not be introduced, or vice versa. The decision is not to introduce a vaccine that could potentially save lives in a cost-effective, beneficial way for the country. The fourth objective is for the decision package that includes all the evidence that I mentioned be developed and be circulated so that a decision can be made. And finally, the rapid deployment, working with countries to do the plan of action to actually take the vaccine and ensure that it gets implemented into action after this policy process. So again, you could imagine when hookworm vaccine becomes available, we now have a platform, a mechanism whereby countries can begin to think critically how the vaccine should be used. It may not be the case in some countries, but certainly in many it will end up, the evidence will prove to show otherwise. The tools can be summarized that we've developed so far in this slide. We focused, based on feedback from our countries, on the 4 vaccines that you see here: HPV, the seasonal influenza, the vaccines against rotavirus and pneumococcal disease. And now we have these tools that countries can use their local data, produce the results, again, to be used in the context of the decision package. And in terms of other capacity in this area of work, you see in this slide this graphic where you see up in the upper left the Ministry of Health, and what we've been able to develop now in more than 20 countries at the national level, working with the Ministry of Health, what we call the PROVAC team. So you have the National Advisory Committee, similar to the ACIP here in the United States, and then you have this PROVAC country team that includes the immunization manager and other supporting experts that will actually think through what needs to be done. Here are the tools that are available. What do we need to do in order to get the evidence to make decisions based on the priorities in our country, to provide recommendations ultimately to the Ministry of Health that's supported by our team in Washington, D.C. In addition to this group at the national level, we have across the region now, I think our first meeting was 2 years ago, what we call the Regional Centers of Excellence. So this is South-South, South-South-North cooperation. So we have 6 centers of excellence situated in such countries like Argentina, Brazil, Colombia, and others, supported by our key partners like Sue Goldie's group at Harvard, the London School of Hygiene and Tropical Medicine, CDC, and a few others that really can provide external international cooperation, and we can share experiences among countries. So this is progressing quite well. And the graph here shows the introduction of vaccines over the last few years, and you can see the uptake of the pneumococcal vaccine, the rotavirus, and the HPV vaccine. We now have over some 21 countries that have introduced the conjugated pneumococcal vaccine. You can see listed here by year. Similarly, it's actually 17 countries now with the rotavirus vaccine. There has been a lag with the HPV vaccine. It's the price per dose is higher, so there are more challenges, particularly looking at the issue of the fiscal space that I mentioned earlier. So in these countries, the evidence pointed to introducing the vaccine, and we've been able to, in this case, shorten the time lag that I referred to as a challenge at the beginning. When we introduce them, these are countries that I referred to have introduced them universally. So they're not piloted in the sense that a certain state or group of states, it's a universal application nationwide. And here are some preliminary data. 81% of the birth cohort within the region was born in countries where pneumococcal vaccine was already included in the regular program. That translates to 73% in Latin America. 86% were born in countries that have already used the rotavirus vaccine, and 44% of girls aged 10 to 14 live in countries that have included the HPV vaccine. Just to show the geographic distribution of the HPV vaccine, we have a lot of challenges going forward in the countries yet to have introduced, largely because the cost-effectiveness analysis shows that the one factor that is the data used to populate the model, the one factor that emerges most characteristic or important in the results is the vaccine price. Now I'm going to switch to a case study. So a country has decided to introduce the vaccine. Now the question, again, in the context of a sense of urgency, rapid deployment. And there's no better way to rapidly deploy a vaccine, particularly when the disease is eradicable. And I'm going to use the case study of rubella. You all know the classic medical school textbook description of rubella, the triad of microencephaly leading to hearing loss, the cardiac defects, and the cataracts. So this is imagine a child with this disease. It's like polio. This child and family is challenged from providing care for the child throughout its lifetime. And the expenses I'll get to in a subsequent slide, but the other issue I'd like to raise with this slide is it's very hard to measure the burden of disease. And the reason is that there are other manifestations. And this is a slide provided to me by my good dear friend and colleague, Lou Cooper. This is a clinic in New York City. Lou was instrumental in defining the epidemiology of congenital rubella syndrome due to the mid-60s outbreaks of congenital rubella syndrome. And this shows other manifestations like autism, like spasticity with deafness, mental retardation, other manifestations that are very, very hard to measure and attribute causality. And I'll get back to this difficulty of trying to quantify the disease burden. It's the same challenge that folks like Peter and others working in neglected tropical diseases have had over the years. But once you did the studies using the DALI methodology, it then emerged as something that's incredibly important public health priority. The way we did it with rubella, though, was a little slightly different, and it'll come out in another slide. This slide shows a cost analysis done by Beryl Irons and Alan Hinman some years ago, and the data that I'm reporting here, the elimination of rubella and congenital rubella syndrome cost 7% of what it would take the health systems of the country to care and provide the rehabilitative services for babies born with CRS. And this could be translated to another message that we've used over and over again with ministers of health. Señora Ministra, for every dollar you invest in congenital rubella syndrome elimination, you will save $12 to $13 in healthcare costs. It's cost savings. And that's a no-brainer for a minister. That's a no-brainer for most people in public health when your investment actually saves you money. And so with the emergence of new vaccines for neglected tropical diseases, whenever we can come up with these kinds of messages, that's going to make a huge difference in accelerating a public health intervention. But not all immunization interventions are cost savings. Rotavirus vaccine introduction is a classic example. It's cost effective and may even get close to breastfeeding as being a cost effective intervention, but it's not quite cost savings. The strategies to eliminate rubella are listed here, and that's rapidly immunizing the susceptible population. That's usually done. The most effective way is a mass vaccination campaign because it's done in a very short period of time, vaccinating your target population with very high levels of coverage. So you're really making a dent in the susceptible population that would sustain transmission over time. Conducting effective surveillance to ensure that you've reached your target, that your strategies are working, that you're making a difference, and also sustaining the gains. Because when you back away, you downsize the strategies. The global polio eradication program in Africa during the last 10 years is a classic example where the strategies were downsized. Polio comes resurging back. So you have to sustain your gains. That's very, very important. And here is where, with measles in the blue bar, with its elimination, we benefited by the fact that it unmasked the hidden burden of rubella. Now, how did it do that? As surveillance for an elimination initiative against measles improved, surveillance for rubella also improved by the fact that, whoa, this test, this IgM test is negative for measles. What else could this be? Well, maybe we should check for rubella. Maybe we should check for dengue. And indeed, that was the experience. And in so doing, the epidemiology was better defined. And in some countries where they actually tested the dengue, they benefited by understanding their dengue disease burden as well. So there were side benefits. And the data speak for themselves. We had a little blip here with a rubella outbreak in 2008 in Chile, but the target was reached in 2009, a year before the target of 2010. So we reached it a year early. The strategy about the campaign I referred to requires that you target all people less than 40 years of age in your country. I'll say that again. You target generally all people in your country less than 40 years of age in a mass vaccination campaign using an injection. Now, before I got involved with this initiative, I would have been inclined to say, wow, you must be nuts. How do you do that? And it is amazing because when you do one campaign well, you eradicate a disease. When you do one campaign well, you eradicate it, you eliminate a disease burden. Now you can eliminate measles, but you have to do more than one campaign, and you have to do it for a few years. And you know the story with polio. You certainly have to do more than one campaign. But our experience with rubella, when the countries went forward, and a few countries like the Caribbean as a group of countries, and then other countries like Cuba and others, one by one, when they show their experience, one campaign can do this, then the whole region came together and said, we can eradicate rubella. What we're really eradicating is this awful disease, congenital rubella syndrome. And so it is pretty amazing, the results have demonstrated. And the other strategy that I mentioned, it gets back to capacity, infrastructure development, and your ability to monitor a program, has to do with surveillance. Surveillance that is linked to the laboratory support. In the next three slides, I'm just going to rapidly show you our laboratory networks for various disease programs, such as, in this case, measles and rubella. It's pretty extensive, with some 148 labs dispersed throughout the hemisphere. We have also for rotavirus, this is more sentinel surveillance rather than the case-based active surveillance of measles or rubella. And similarly for the pneumococcal laboratory network. So over time, with a long-term vision of ensuring that you have the capacity to monitor. And in each of those areas of work, the work that goes into bacteriology is different from the work that goes into virology. You would think you could integrate, but at the technical level, there are challenges. You need specificity in your expertise and in the studies that you have to do. So you have to develop the capacity accordingly. Now, I'm going to end with a few slides showing this opportunity we have with the Revolving Fund of PAHO that will be certainly a benefit when vaccines for neglected tropical diseases become available. And related to the Revolving Fund is the basically the sustainability issue that countries have addressed over the years, with these data showing the number of countries that have vaccine legislation and those that have funded their vaccine. So there are a couple of very important points out of this slide. One is the number of vaccine laws that have been introduced into countries. And these laws basically say, in the context that vaccines are a global good, that our country needs to ensure our children are immunized. And in so doing, we need to have a budget line in our national budget for vaccine purchase. What better way to sustain an immunization program? What better way to sustain the introduction of a new, more expensive vaccine? It also shows the proportion of the vaccine costs funded by the country. So you see that proportion has grown over the years, and even with the more expensive vaccines, it's sustaining itself in terms of the national commitment and ownership in our countries. So getting back to the Revolving Fund, it was authorized in 1977 by a directing council resolution, and it was really the result of the genius of Dr. Cyril de Quadros, who had this incredible vision to link vaccine supply, couple it with the technical cooperation. So if you're sitting there with the EPI manager and you're saying, okay, let's discuss how we're going to eliminate congenital rubella syndrome. You know, what are the strategies? Where, you know, what is your epidemiology? What kind of labs do you have, and what should, from this analysis, be your plan of action? Then you start talking about, well, how many numbers of doses do we need? When do they need to be here? What kind of cold chain do we need? And that's what the fund can provide: vaccine and cold chain. And it is a pooled purchasing mechanism, so it uses economies of scale. So if I'm El Salvador negotiating with a company, my price is likely to be much higher than if I'm El Salvador pooled with all the other countries of the region. That is a critical point. And it consolidates the regional forecasts into more accurate demand forecasting. The quickest way you can increase a vaccine price is to tell a country you want 1 million doses, but at the end of the day you're only purchasing 500,000. So the company is sitting on 500,000 doses that they weren't able to sell, but yet they had to invest in the production. That's the quickest way to increase a vaccine price. I know that from experience. That's been our experience over time with the revolving fund. So you need accurate demand forecasting. And I can't say enough about that. We do it virtually as a service to the countries. You know, we're the secretariat. We serve the countries. That's our mandate. But we do ask them to provide a 3% capitalization fee. And I'll get back to this. So they purchase, PAHO does all the contracts, the negotiations, the bidding, the insurance, the shipping. Once the vaccine reaches the airport, they pick up the vaccine and take it over. And we do that using economies of scale. The key benefits, I mentioned the economies of scale, the reduced administration because we do the transaction costs, we do the bidding and negotiation, the consolidated regional demand. If we can demand more, that helps justify a lower, more affordable price. And it really has accelerated the uptake of the new vaccines along with the other work we're doing with PROVAC, along with the other work we do with the Directing Council, governing bodies, and all the other efforts of our partners. All these lead to, I think, more rapid progress. But at the end of the day, we're able to guarantee a reliable and safe supply of vaccines because we only purchase vaccines that have been pre-qualified by WHO. What does that mean? Pre-qualification is a process that WHO uses. It's very rigorous, that puts a stamp on the vaccine that Serum Institute of India uses, or sells. We can buy that vaccine, that Merck or GSK. It is a stamp similar to FDA process. So I have, in the next minute, I will end. This shows the effect of the fund in sustaining the vaccine price of pentavalent, which includes DPT, Hib, and HB, hepatitis B, over time. And you see the uptake of the number of countries, but this price here has been sustained. So countries know what they're getting, and they can count on it. Just to say, the growth from 1979 when it started to 2011, we've gone from 6 antigens or vaccines to 28, from 8 countries to 39. We purchase now more than $400 million worth of vaccines. There are 2 mechanisms. If I'm a big country like Colombia, I pay PAHO up front to buy the vaccine. If I'm a small country like El Salvador, the revolving fund component is like a credit card. I ask PAHO to pay for the vaccine, and I'll pay you back like a credit card account. And that's the concept of the revolving fund. So the small countries benefit. They can take a borrow, but they have 60 days to pay it back. And that's a very strict rule that we manage. Again, to show expenditures. So in summary, we don't believe there's a magic bullet, but we believe that with good vision, with the investment in capacity, that countries will ensure the sustainability of their program. I paraphrase what has been written here, but again, I just want to thank Peter and the organizers for inviting us, and to be able to tell you our experience, share with you our experience, and that we're really positioned and we're really looking forward to tackling the challenges of introducing newer vaccines, the dengue vaccine that's going to be emerging. And our PROVAC initiative in phase 2 will focus on that, and others such as hookworm that will make a huge difference in the quality of lives of our citizens of the hemisphere. So thank you very much.